Nope.
Let us begin. Okay. Um, hold on. I'm trying to see. Am I recording? Hold up. Oh, it's recording.
Yes.
Okay, it is. How could you tell? You could tell?
Yes. It says recording on the top.
Yeah,
On the
what?
left.
Look, I swear, I need to get better at this. I sound like an old person. I'm gonna learn how to use Zoom. Okay, come on now. Before coronavirus, how often did you guys use Zoom? Seriously.
Never.
Never. Of course. Okay. So, yeah, if we were on FaceTime, I got that. We could have I'll get you through, but not Zoom. So I'll take some classes over the weekend. Death, dying, and end of life care, right? So this is just a little quote from a hospice nurse. And what I have learned, hospice is more about quality of life than it is about death. And that is so true. Um, the Institutes of Medicine. This is, they write a lot of guidelines and produce a lot of research that we use. Remember, you're going to hear this term for the rest of your career: evidence based practice. Um, we use the things we do and the reasons we do them is based on evidence achieved through research. Oh, I done spelled research wrong. Oh, see, that's why I don't put the slides up right away. I'm gonna go back. I'm gonna fix that. But anyway, so Institutes of Medicine, this is the actual document and research they did. You don't need to know this for your test, but it's just to give you an idea. They recognize that dying in America, this was an issue. End of life and end of life care in America is an issue that needs to be addressed. So they wrote some recommendations on how we can improve the end of life care. This was produced like around 2015, I think. So their recommendation is we need widespread and timely access to end of life care. We need comprehensive coverage for palliative care services. We need improved communication between providers and greater emphasis on advanced care planning, professional regulation and professional education and development, and a stronger public education and engagement. Again, knowledge is power. Education and information is what empowers people. Death and dying. Death is obviously, your heart stopped beating, you're dead. I mean, there's death. You're dead. No breathing, no heartbeat. Beliefs towards death obviously are influenced by the same factors that influence our beliefs towards health: culture, where we're from, our family practices, our religious beliefs. Those things influence our beliefs towards death. So as a nurse, you need to understand that death is a natural process. It is a part of life, and it's going to happen to each and every last one of us. Um, so, because of that, we are nurses and we care about the whole person. We provide holistic care. So, we need to treat death as if it is just as important as birth. Planning ahead. So, the law states, and I'll tell you about that on the next slide, you must assess for advance directives at every primary care visit, and or at least routinely at primary care visits, and also for your sake as an RN in the hospital, every admission you must ask the patient, do you have any advance directives? No matter what hospital you work at, no matter what state you live in, that is a federal law. And you must ask about advance directives. You must also, if the patient does not have advance directives, you must provide them with literature and education on advance directives. The purpose of this is people are making these decisions way too late in the game, way too late in life. Advanced directives are just those written documents that people prepare to let their loved ones and healthcare providers know exactly what their dying wishes are. Right here, you see the actual Florida DNR form, okay, on here. A person will fill that out, and they these check boxes here are just saying who's filling it out. Is it the actual patient or is it a family member? Yada yada. The patient will fill this out and they will sign it. It will be signed by a witness, but it means nothing if it is not signed by a physician. If it's not signed by a physician, the DNR is null and void, regardless of what the patient says. You will have to call the doctor and get an order for a DNR. Now, other advanced directives, again, these are highlighting what your medical treatment will look like at the end of life. It doesn't simply stop at CPR. In your living will, and I'll go to that next, there's other things you may address. In Illinois, where I have worked most of my career, our DNR form looks a little bit different than this. Our DNR form includes check boxes that also say, you can decide, yes, I want CPR, but no, do not intubate, or do not provide CPR, but even before that, do not intubate, DNI, or do not insert feeding tubes. Do not give me life-saving interventions. Vasopressors, we'll talk about those next week or 2 weeks, but those are the drugs that cause your blood vessels to constrict. Pressors are only given in the emergency room and in the critical care setting. Those are used for people in shock and things like that. So basically, those are still life-saving measures that people can decide, look at all these people in these nursing homes, um, I bet half the people living in a nursing home with a G tube and all that, if they had the opportunity to go back to when they were 40, they probably would have came up with a plan as to, please don't leave me in some nursing home that smells like pee hooked up to a G tube for 10 years. Please don't do that to me. So everybody has their preferences. If we educate people early in life, earlier on, middle adults, 40s, start talking to people about this stuff. Um, it will help promote dignity with death. Advanced directives, again, we already went over the DNR. No CPR. If a person has a DNR and you perform CPR on them, that's battery. You could be sued. Your facility can be sued. Your facility can be closed. Anybody that works in a nursing home, I believe, performing CPR on a DNR is what they call an IJ, meaning you get a tag from the state. IJ, you are in jeopardy of closing. Whole facilities shut down because you done perform CPR on a person who had a DNR. So that just shows how much we need to consider people's death. People should have the opportunity to die with dignity, and if they don't want all their ribs cracked open and they don't want to be kept on a ventilator for 4 additional days and still die, we need to honor that. So again, the order must be signed by the physician. And in the absence of the written DNR, happens all the time, you must attempt to resuscitate and CPR. So usually the practice in Florida is, and pretty much anywhere, the DNR is the first document in the chart. DNR is on top of the face sheet, it's on top of everything. And that bright yellow form, you want it printed on a color that's bright so it stands out. So in the event that your patient codes, you're not sitting around flipping through 50 pages trying to figure out was the patient a DNR or not. Advanced directives should be shared at every change of shift. Every time you hand a patient off to the next nurse and every time you receive a patient, you should know, is that patient a DNR or not? Because anything can happen and they can code at any given moment. And if you're scrambling, I thought they were a DNR, I think they're a DNR, Well, now you might be sued because you have prolonged providing that person CPR and saving their life. The living will is just, it is the document that tells you all those other things outside of CPR. Durable power of attorney and healthcare proxy are pretty much the same. Those are people who are those are people who are sorry, making healthcare decisions for you once you're incapacitated. Um, Durable power of attorney, it must be of healthcare. If it's just a power of attorney or power of attorney of finance, both of those only have to do with finance. Durable power of attorney of healthcare, it must say that. And then the Patient Self-Determination Act is that law where I told you where you have to assess advance directives on admission. Organ donation, I just included this stuff in here. Again, it's a refresher from fundamentals, but all these things must be considered when you're talking about death and dying. It is federal law that in the event of a death, the hospital must notify an organ procurement agency. So when somebody dies, this is the process. You're in the hospital, your patient died, right? You're on the floor, and whatever the case may be, they died. You're going to call the doctor. You're going to let the doctor know that their patient has passed away. You're going to call family if they're not already there. Obviously, hopefully, you would have prepared for that beforehand. But some families, they don't want to be there. So you're going to call family, and then you're going to call the organ procurement agency. I don't know who that is for Florida. I know in Illinois we use Gift of Hope, and that may be the same here in Florida. But basically, you're calling them to make sure the patient is on the see if the patient is on the registry. If they're not, they will determine based on the questions they ask you if that patient can donate organs. You'll be surprised. Just because a patient is elderly, they may still be able to donate their corneas. Organ donation can save so many lives, but again, it's about educating patients. It's about cultural beliefs, religious beliefs. Not everybody feels the same way about organ donation. So you really, our job as nurses is to provide transcultural care. So know the facility policy, but again, while this is a sensitive subject, it also needs to be done in a very timely fashion. Those organs aren't going to last forever. We need to be calling organ procurement quickly, and they are usually quickly going to want to talk to the family. If that patient, didn't sign at the DMV that they wanted to donate organs, they are going to want to talk to them, and you're going to feel like so protective of your patient and their family, like, what a jerk. Why do you want to talk to them now that just their husband just died? Now you want to talk to them about some kidneys, if you could have their kidneys. Like, but you have to realize, again, death is a normal part of the living process. And while everyone has their own beliefs, let's think about it physiologically, physically. What do you really need those kidneys for? There are people in their 30s, young girls with lupus who are dying of kidney failure, waiting for an organ, so a lot of ethical issues surrounding that. So, when it comes to end of life care and dying with dignity, obviously the goal is to provide a good death, a death that is free from avoidable suffering. Palliative care is basically the patient has made a decision that they no longer want curative measures. They no longer, maybe it's a patient with dialysis, on dialysis, and they no longer want dialysis. Or maybe it's a patient, whatever the case may be, they don't want like medical treatment. They rather just have symptom management. Okay. Now, there are things that we do palliatively, right? Say say your patient has liver failure and they have ascites, sorry, ascites, this big belly, right? From liver failure. You get all this fluid buildup in your belly, ascites, and we'll talk about that later. But while it seems like a curative measure, the procedure of paracentesis, where they stick a needle in your belly and drain that out, and it's done at the hospital or outpatient, surgical center, that procedure, it is an outpatient thing, but while it may be curative, it may also be curative, and that is, say they may be having pain and shortness of breath because their belly's so big. Is paracentesis going to cure their liver failure? No, but it is going to provide relief of the shortness of breath symptom and the pain symptoms. Hospice, the thing that sets hospice apart from palliative care is that we know these people are dying. The ones receiving palliative care, while they may have advanced disease, people going into hospice have a life expectancy of 6 months or less. Okay, so that has to be the criteria. I mean, that's the criteria. Um, you will not be referred to hospice or accepted into a hospice program without meeting that criteria. And usually at this point, it's inevitable. I mean, we can do all these curative measures, but you're likely still going to die. So we talked about it already, palliative care, what it is, basically symptom management, improving quality of life. You can perform palliative care in hospitals. Same with hospice. It can be done in hospitals. It can be done outpatient at home. It could be done in skilled nursing facilities. Readiness for hospice now. Death must be accepted by the patient and the family. They must have come to the realization that they are reaching the end of life and that death is approaching. Some people never reach that acceptance, and therefore hospice is not appropriate for them. It is not our duty as nurses to it's not my job to put my values and beliefs on you. What makes the world a beautiful place is we are all different. We have all different stories to tell. We're different colors. That is what makes this place beautiful. But unfortunately, um, some people don't understand hospice, and they don't understand, some people, it's their belief that they need to fight till the very end. So death has to be accepted by the patient and the family for hospice to work. Because they can no longer, when you decide to sign up for hospice, you're giving up your right to curative measures. You're giving up your going to the hospital or emergency room because you have accepted that those things are not going to save your life, but likely just prolong your suffering. Um, Obviously, total care is managed by it's her disciplinary team. There's all different members on the hospice team. You have music therapy, you have a chaplain, you have all different things. It depends on, who the hospice agency is. Pain and symptoms are managed. You must view the patient and their loved ones as one single unit. This is where family centered care is really big in hospice, because you're taking care of not only the patient, but those people who are anticipating and preparing for death and even after death. Bereavement is the care, is the time period that the person is grieving. So the bereavement, most hospices have a bereavement program as well. They offer support groups, and they have little events, honoring the life of their patients that have passed. Bereavement is also part of the hospice process. Um, let's see. And yep, research and education. Of course, this is still a hot topic that people, are still not comfortable with death. So, and because of that, that's how we end up with these barriers. Not only are regular people, oh gosh, I gotta redo that. This families, the second line should be at the bottom because this other list right here goes with the physicians. So I'll fix that. But um, some of the barriers to hospice are physicians' reluctance to refer. Um, and their reluctance may have to do with their own personal beliefs. Their reluctance may be that, it is hard to tell somebody you're going to die. Who wants to be that person? Who wants to tell that person we've tried everything, especially when they're young? That's when it really becomes hard. Or when it's a child. Um, who wants to tell them that their prognosis is poor? Prognosis is what is the likely outcome. And when the prognosis is poor, it's terminal. Terminal meaning it's going to result in death. Um, there's a strong association with hospice and death. Honestly, our problem is we're referring people to hospice like the day before they die. That pretty much defeats the purpose. If you know a person only has 6 months to live, it would be best practice to refer them then if they're ready, as long as they meet that. Why? Because it gives them the time and the opportunity to become more accepting of the inevitable. Um, Now, also, something I said, if a patient signs up for hospice, it's not like set in stone. If that patient changed their mind and said, nah, forget that. I heard about this new drug on the market. I want to join this clinical trial and see if they can save my life. All they have to do is simply tell the people in hospice and sign a form saying that they are going to revoke hospice. They don't want hospice anymore. If they go to the clinical trial and it doesn't work and they're still about to die, they can always come back and get hospice again. You can flip and flop. The only thing is, you can't get both at the same time due to insurance purposes. Because remember, healthcare is a business. Um, so because people think hospice means dead, they don't end up signing up for hospice until the very last minute versus, earlier on. Obviously, advances in science and curative treatments, um, make doctors and patients more reluctant to accept. And also, there is healthcare providers um, are faced with financial pressures. It's To me, the business aspect of healthcare is why I moved into teaching, and I haven't been doing patient care for the last couple of months because for me, it's just too disgusting the financial pressures that are put on us as providers, doctors, nurse practitioners, and even nurses. You will see a lot of ethical conflict in your career because we are just so all about the money. So doctors will wait to refer to hospice because, of course, now they're losing that check. That patient is no longer coming to see them, or they're no longer getting these big, expensive treatments or procedures. So now they've lost that check. And then, of course, family and patients' reluctance, like we already talked about. Services in hospice includes routine home care, respite care. Does anybody know what respite is?
Yes, that's like a day club, or
Y-
like when the caregiver is going away, they could put their loved one there for like a week or two.
Yes. So respite is simply that it's a break for the loved ones. So if you were going out of town, yep, when you may need or if just the process of taking care of somebody is stressful enough, or your parent has this advanced dementia and they're just so restless and abusive or combative at home. Shoot, call them hospice people up. They usually have some, not usually, they pretty much always have somewhere to provide inpatient respite care, whether it be an affiliation with a hospital that has some beds reserved for that, or if they have their own inpatient hospice. Um, Continuous care, blah, blah, blah. And again, it's holistic. So there's going to be a lot of people involved when it comes to hospice. They may get pet therapy where somebody brings them a little dog and they get to play with the dog, or aromatherapy, art therapy, music therapy, those kind of things. Anything that is going, whatever you tailor, maybe your patient isn't into none of that, they don't want none of that, just bring the nurse and bring me morphine and I'm good, then of course you don't need those people. So you tailor the plan to their needs. As far as a nurse, as I already stated, you need to assess their advanced directives on every admission. You also need to look within yourself and try to develop over, and it comes with time and exposure and practice, a level of comfort and expertise when communicating with people. You can't be bursting into tears every time you talk to them. Don't get me wrong, I'm a crybaby, boy. I cry at work all the time talking to patients, but um you are also, they're looking at you for a little bit of hope and comfort. So you need to be comfortable, interacting with people who are dying and talking to loved ones who are facing anticipatory grief, which is grief, knowing what's about to happen. um and again, communication, again, meet people where they're at, make sure you discuss it in a level that they can understand, create the right setting. You want to include everyone that be included. You only get this opportunity once. So families have all types of crazy dynamics, and it's nothing like a crisis or a loss to bring out the craziest dynamics you'll ever encounter. So make sure all family members are included. Schedule family meetings when it's time to talk about that. Of course, you are not the one to make a recommendation for hospice. That is a physician's job, the provider's job to have that discussion, because they need to make sure they are giving them accurate medical information. Active listening. This is your role. Let people talk. Listen. Leave that empty space empty. Sometimes less is more. Just sitting and being there with somebody. Sometimes you don't, people like me, I talk a lot, so I get uncomfortable when it's quiet, but you have to learn how to sometimes just leave that space open, allow time for people to answer your questions, time to think. Um, but yeah, and then avoid distractions, giving advice, trying to compare your life experience to theirs. Oh, I know exactly how you feel. That happened to me, or this happened to me. Don't nobody care about what happened to you. That's not what we're here for. We're here to take care of the patient and the family. While you have that experience in your life, that is great. And that should help you be able to put yourself in the other person's shoes. You don't need to share that experience with them while they're going through what they're going through. It takes away and it minimizes their feelings. And this you'll talk about in mental health as well. And also assess your understanding and your own beliefs and values towards death. Oh, I'm sorry, and also towards what the patient or family member has expressed to you. You're always going to kind of, when it's over, you're gonna restate to them, okay, so what I've heard you say is blah blah blah, to really make sure you understood their perspective. Physiological changes happening in the body. The patient may start to sleep more. They're going to be more withdrawn. They're going to sleep longer. They may be more somnolent or difficult to arouse. They're going to have changes in their respirations, increase, like, slower respirations, chain Stokes respirations. That's the type of respirations preceding death. A weakened and irregular pulse, diminished blood pressure, and also modeling of the skin. Does everyone know what modeling of the skin is? Like, oh my gosh, it looks so mottled. Yes, it is that purplish discoloration. And I'll post some pictures in Moodle. Again, nursing interventions, you're going to administer meds for different symptoms: pain, dyspnea, anorexia. Anorexia is the refusal to eat. And now, from a hospice perspective, giving someone medications to stimulate appetite is kind of counterproductive, right? The person is dying. It is totally natural that because they're dying, they no longer need energy, right? They're going to have a decreased appetite. But for a lot of families, it is very difficult to witness. And because of that, they pressure the healthcare provider to give the patient meds to stimulate the appetite. But as the body is dying, it does not require energy. It requires less and less energy until it's dead. So the appetite will disappear. Um, Now, the patient died, post-mortem care. Like I told you, you're going to notify the physician. If there's no autopsy, you're going to remove all the lines, tubes, IVs, so that the family can view the body. You're going to be a part of getting the family member to fill out, at the right time, not immediately, but you're going to give them time to fill out a death certificate information. You want to allow the family time to stay with the body as long as they desire. When it comes to peds, allow the family to hold the body. If it's a baby, if it's a small child, allow them to rock the child and hold the body. They may need that. They may need to assist you in preparing the body, cleaning them up, getting the body prepared for the family, the rest of the family to see. I know, moms probably, before the other family members come to grieve with her or mourn with her, they may want to do everything, bathe the body and everything. Remain with family as much as you can and allow them to have as much time as they need. And then, of course, assist with preparations. You're going to contact the funeral home, etc. Grief is that feeling, the feeling that person's perceptions and feelings they're going through. Mourning is an act, is the act of grieving that the family does. Bereavement, again, is that period that grief and mourning takes place. And there are different types of grief. Anticipatory, like I said, is you are anticipating that you're about to grieve, you're about to have this loss. So there's anticipatory, there's complicated. Now, anybody who's actually had someone in their family die, you definitely know that that grief can last more than a year. The closer you are to somebody, it can take time. So, for the purpose of ATI and NCLEX, complicated grief extends more than a year. Textbook states that you should be able to cope with that loss within a year. Hurry up, get over it, get back to work, and all that. Um, and like I said, I've lost one of the closest people to me in my life was my grandmother. And that grief could still hit me like a ton of bricks today. And that was 6 years ago, well, 5 years ago. So I can't imagine being a parent. And that is why parental grief is much different. Parental grief, you're going to expect intense, long lasting, and complex grief. Their grief is going to be complicated. Losing a child, especially a young child, I'm not, even older people, when they lose an adult child, are devastated, but a young child, especially. Um, See, Moodle, yeah. So I'm posting some more resources so you could see all the different ones as far as age goes. And then the last thing, grief. The grieving process consists of 5 stages. There's denial. This isn't happening to me. There's anger. People can become angry at themselves, angry at God, angry at, family members can be angry at each other, blaming each other. Death and loss brings, a lot of ugliness out in families. Bargaining may be, God, if you please save my mom's life, I'll go to church every day of the week. God, please, if you can just give me 6 more months. Doctor, I will pay you $1 million. Just please give her a couple more months. That's the bargaining part of grief. Depression and then acceptance. We know what those are. And then interventions, obviously, you're going to support their feelings, social support, coping skills, yada, yada. And if they need a referral, you're going to take care of that. So that is death and dying. And like I said, videos will be posted. The slideshow will be posted, and I will also be adding some additional resources. Does anybody have any questions about grief?
No.
Wonderful. Any questions about next week, this week, any week?
No.
No.
Speak now, forever hold your peace, because I'm about to
No.
get
Are we on campus next week?
Oh, yeah. So what I said was, it's up to you.
Okay.
The school cannot make it mandatory. Now the exams are mandatory, and you've been notified of that. However, the school cannot make it mandatory that everybody come to class without giving you a 30 days notice. So, if you are planning, if you want, you can come on campus. I will post an announcement about that, and I will be in room 104. And if you don't want to, or you can't come, then we will be on Zoom like we're doing right now at the same darn time. So that's that. Anybody?
Perfect. Thank you.
You're welcome.
Thank you.
Everybody have a good day. And
Thank
I'm
you.
trying not to
Thank
talk so
you.
much next week.
No, you're
Thank you. Have a
fine.
good week.
All right. All right. Toodles.
Bye.
Yeah, bye-bye. Thank